Well, I've been invited here to talk about the experience that we've had over in England with using comparative effectiveness review to inform the decisions that the health service in England takes about what new technologies to acquire. It's a big influence, yes. I mean, our recommendations aren't mandatory, so there's not an instruction for the health service to buy or a formal recommendation that prevents them from buying in other cases. But what we advise is based on the clinical effectiveness and the value for money of new technologies. So it's a pretty big influence on what the health service uses. In favour of it when it's done well, and that means making sure you get all the evidence together, you involve everybody who's affected by the decision potentially, including the manufacturer of the product. That's really important. And then you've got a transparent process for making an assessment of the benefits of a new technology compared to current standard practice. In the UK, but it's not necessarily the case in the US, you don't need to do this. You can go one step further. Once you've made a judgment about those incremental benefits, once you find out just how much better a new technology is, what more it offers, you can go on to make a judgment about whether that additional benefit is worth what the health system is being asked to pay. So that's cost effectiveness. But you can do both of those things. You don't necessarily have to do the economic evaluation as well as the evaluation of clinical effectiveness. Well, just look at the experience that we've had in the UK. Most technologies, most new things, medical devices, pharmaceuticals that we look at bring useful additional value in any healthcare system. And most of the recommendations that we make based on our evaluation are positive. So we've had a really big effect in the UK in pushing effective and value for money products into the health system much more quickly than if the health system had been left to its own devices. But what you have to do, this is really critical, what you have to do if you're going to use comparative effectiveness reviews as a process is to fit it into the health system in which it's being used. You can't take what happens in the UK and transplant it to the US or from the US and put it in Germany. You have to look at the health system, look at how it works, align objective cost effectiveness reviews with the ambitions of the health system. If you do that well, then it really does work. Well, everybody learns from everybody else. When my organisation was established in 1999, we looked at what happened in Canada, in Australia, in the Netherlands, and we took the best of those practices. We took the ones that seemed to fit what we needed in the UK, and that's the way to do it. If there's interest in the US in developing more of a capacity, because it already happens here, lots of different parts of the US healthcare system, people are already doing different kinds of comparative effectiveness reviews. So everybody learns from everybody else. There's no one great way to do it, apart from the one that we use, of course. I'm quite happy to acknowledge that there are other ways of doing it. Just one thing that's really important. I'm not here to sell NICE or its processes into the US. That's not what it's about. But I am a pretty passionate advocate of objective assessments of new things that come into any health system, because none of us have got money to burn. We need to make sure when we buy something, whether it's an individual physician or a whole health system making a decision, that the money is well spent. We're getting real additional benefit for patients. And I think comparative effectiveness review, it's not the answer to every problem, but it's an important component, I think, of the solution.